Hi guys, it's Amy. I'm going to record lecture on phosphorus now. Phosphorus is, excuse me, also known as phosphate. You will hear that some people use that term interchangeably. Anyway. You can see that there are a couple ways this can be measured, and it's all based on the way the lab is doing the test. It can be milligrams per deciliter or milliequivalents per liter. The most common one is this 2.5 to 4.5. If you can remember that. Sorry, I don't have any little memory aids for that. Phosphorus is important for muscle function, neurological function, metabolism of fats, proteins, and carbohydrates. What is ATP? It is made up of phosphorus, right? Of a phosphate, adenosine triphosphate. It also makes up a part of the red blood cell that carries oxygen and is an essential part of bone and teeth. If you've ever heard of, and I know there was one point maybe back in fundamentals or something that you heard of, something called 2,3-DPG. That's a part of the red blood cell that carries oxygen, and it's made up of phosphorus. It is excreted primarily through the kidneys. It is absorbed in the jejunum of the GI tract. But as you can see, if 90% of phosphorus is excreted through the kidneys, that's going to help you understand what symptoms are going to occur and what things are going to cause hyper and hypophosphatemia. Parathyroid influences calcium, and calcium and phosphorus have an inverse relationship. So if calcium goes up, phosphorus goes down. And it's sort of like, I kind of think of it as the bones, when calcium comes out, phosphorus goes in. And the opposite when we're talking about phosphorus coming out, calcium goes in. If you remember, we talked about insulin causing potassium and magnesium, and now it also causes phosphorus to shift into the cell, helping to decrease serum levels. Phosphorus is an intracellular anion, and it helps you understand that 2.5 to 4.5 is quite a smaller number. We also know that phosphorus is related to white blood cell phagocytosis. If we have an abnormal phosphorus level, it may impact our infection susceptibility. And platelet functions are also affected by phosphorus. Here are some foods that are high in phosphorus. Let's look through some of the ones that are outliers. Eggs, fish, poultry and meats and milk, I guess, are high in those. Here's the thing. If you look at this, a majority of those are also high in calcium. And so calcium and phosphorus have an inverse relationship. So it may not be enough. If it's increasing the calcium in the body as well, then we may need to look more towards a phosphorus supplement, such as Nutriphos or K-Phos. When we're looking at low phosphate or phosphorus, this is below 2.5 milligrams per deciliter. The causes are basically things that cause hypercalcemia, remembering that inverse relationship. So what kinds of things caused hypercalcemia? Do you remember? Cancer, hyperparathyroidism, antacids can cause hypercalcemia. If we have malabsorptive issues, laxatives and starvation. As we have said, diet or GI absorption has been important in all of these. Here again are your loop and thiazide diuretics. We also can see acetazolamide, which is used for glaucoma. It's a medication used for that, can cause low phosphorus. And importantly, you can see the insulin. We know that insulin causes a shift. But why diabetic ketoacidosis, or DKA? It's because DKA, there is an increased urination, which causes an increase in the excretion. And if you remember, 90% of phosphorus was excreted through the kidneys. It also changes in, there's a change in acid-base balance with DKA. And, excuse me, again, it causes that osmotic diuresis. This is the second most common cause. The primary cause of hypophosphatemia is the use of diuretics. All right, so with hypophosphatemia, we see a decrease in metabolic activity, if you will. And my mnemonic here is low, which is helpful. It helps you, that's an easy mnemonic. Lethargy, confusion, osteomalacia, or rhabdomyolysis. Myelitis is, in severe cases, that is a breakdown of the muscle. And weak muscles. Those weak muscles can lead to weak muscles of the diaphragm, therefore leading to respiratory arrest, and the person may need to be on a vent. If we have low phosphate, we can increase our diet with foods rich in phosphorus. Remembering, what were some of the foods rich in phosphorus? Eggs, poultry and meats, fish. And we can give supplements such as K-Phos and Nutriphos to help. We do not want to take Nutriphos with an antacid, as that will increase our calcium level, right? There is also a phenomenon about people who are on TPN or who have been starved, who have had extreme severe malnutrition, and we start refeeding them. The phosphorus, after about 3 days of eating, we will see this significant shift of phosphorus intracellular, and it will cause a severe hypophosphatemia. And like I said, it's about after 3 days of eating. So if you're ever dealing with, maybe you're a missionary, or you're in a third world country, or even here, there are people, unfortunately, with severe malnutrition. You should be on the lookout for low phosphorus. High phosphorus, greater than 4.5, causes of that are kidney failure. Why would that be? Well, if they're not putting out the urine, we said that 90% of phosphorus was excreted by the kidneys. The things that cause the phosphorus to leak from the intracellular space to the extracellular space, such as chemotherapy. We already talked about in a previous section how chemotherapy causes cells to bust apart and lose the contents within the cell. Respiratory acidosis is another thing that can happen, and DKA. Which again is can cause low phosphorus as well. However, if it causes leakage, then it can cause this as well. And obviously increased dietary intake. When we're looking at hyperphosphatemia, we are looking at an increase of symptoms, an increase of metabolic neurologic activity. Kind of. We see a decrease in CNS and an anorexia, so those really don't. But we see a neuromuscular irritability. Why do you think we're seeing Shavastik's, Trousseau sign, extremity tingling, decreased CNS, anorexia. Where do you think that might come from? If you remember that inverse relationship with calcium, this would be hypocalcemia. And if you remember, hypocalcemia, I hate cats, remember? And so we see the convulsions, the arrhythmias, the tetany. If you think of through all of that, we see a positive Chvostek's and Trousseau sign with that. We see spasms and stridor. So if you look at it, much of this is kind of just the same thing as low calcium. If you have somebody who constantly has a high phosphorus level, what will happen is it will bind with calcium, forming a calcium phosphate compound, which is deposited in organs. And I kind of think of it, calcium and phosphorus together seems like a hard substance, and so it can cause lots of problems. So if we have a high phosphorus level, we want a low phosphorus diet. We want to choose some phosphorus binding antacids taken prior to meals. There are some out there that you take prior to meals and it will bind with the phosphorus as the person eats it. People on with chronic renal failure who are on dialysis almost always have these supplements because they are extreme risk for high phosphorus. You can see, remember we talked about the fact that phosphorus has to do with the part of the red blood cell that helps to carry oxygen. And so people with chronic renal failure who have a